This lesson is about pneumothorax, so let's talk about the pathophysiology. So pneumothorax, pneumo meaning air, is when it enters the pleural space and causes the partial or total collapse of the lung. Now, normally these two stick together. Think of two plates with water on them. Ever try to pull them apart? Normally there's negative pressure that holds that together, but now we have air. You can have an open pneumothorax where air enters through a hole, so you're thinking some kind of trauma, maybe a gunshot wound, or even closed. This typically happens during surgery or maybe after a central line placement. If that closed pneumothorax gets worse, we look for tension pneumothorax, a medical emergency. This is when air enters that interpleural space, but it can't get out. And what happens is we have an affected and possibly unaffected lung collapse. Both can go. Our trachea will shift to that unaffected side, and our heart and great vessels are compressed. We don't have venous return back to the heart, which ends up in hypotension and lack of perfusion. What are the clinical features of tension pneumothorax? Well, we're talking about hypoxia here and a collapsed lung. So you can imagine our patient is going to have progressive dyspnea. They're going to be very short of breath. They're hypoxic, restless, anxious. They're progressively going to be cyanotic. Chest pain, they could have hypotension and tachycardia. Remember, we have our great vessels compressed. That inferior vena cava is not returning blood to the heart. Our O2 sat is definitely going to drop, and usually the physician will order a chest x-ray in a stable client. So how often do these patients sound stable? Let's look at assessment findings of a pneumothorax. One thing you can see is hyperresonance to percussion. What does that mean? Well, when you percuss the patient's lungs, it's going to be a very low pitched. Of course, there's going to be diminished lung sounds, especially on which side? The affected one. You're going to have decreased tactile vocal fremitus. What does that mean? It means when I put my hands on the back of the patient and have them speak, I'm not going to feel that air movement as much as I would before. I'm not going to feel that vibration, right? Because I don't have air flowing back and forth. Your patient's also going to be hypotensive, which we talked about from that decreased venous return. Let's talk about nursing interventions for a patient with tension pneumothorax. We're going to place a 3-way occlusive dressing over that sucking wound. Now, what is that going to do? When our patient breathes in, it's going to seal and not let air into that space. When they breathe out, air can come out, and sometimes you might see fluid too. Definitely keep your patient in a Fowler position. We would allow for lung expansion if possible. Now we need to prepare for a chest tube, and we're going to connect it to a drainage system. This will allow air to escape and not let air to re-enter, which is what is causing the tension pneumothorax in the first place. Hopefully that negative pleural pressure can be reestablished, right? Our two wet, sticky plates will suck back together. The lung will hopefully then re-expand. This is a picture of a chest drainage system, and it's going to measure and collect fluid and also let air to escape through a one-way valve. Now you might see a word called titling, and what that means is as the patient breathes in and out, you can see fluid move in and out and tidle in your drainage system. When the lung re-expands, though, titling will stop, which is a good thing. You might also see bubbling, which can be indicative of an air leak. Now, keep in mind that continuous bubbling in the air leak monitor is bad, but if your patient coughs, they stand up, you might see intermittent bubbling. The suction chamber is where their negative pressure is applied to the system. Now, if you have a wet seal chamber, that's going to be continuous bubbling. If you have a dry seal chamber, it won't. So make sure that you compare the two so you're ready. We need to make sure that we're assessing and administering pain medications for our patients with a chest tube. Remember, this is a surgical site, it hurts, and they might have referred pain back at the scapula. We need to ensure that the system is closed and has no links or kinks, and we're going to do that from assessing the dressing site all the way down to the seal. We need to ensure that there's no dependent loops in the tubing. This can change the pressure that's preset in the drainage system. We need to monitor the volume and characteristics of drainage and notify that healthcare provider if the drainage exceeds 100 milliliters an hour or if we have sudden, bright, free-flowing drainage. Although I will tell you, when your patient's been sleeping all night and stands up, you might see a little extra in the morning. Keep that collection device below the insertion site. Think about it. Would you ever hold a Foley above a bladder? It's going to be the same principle here. Do not routinely strip the tubing, meaning if you see a clot, do not press the tubing to try to get it out. That will also increase the pressure inside of your patient's chest cavity. If you see any drainage, definitely reinforce that occlusive dressing and ensure that the client has appropriate chest x-rays, which is always going to be if there's any kind of changes in your patient's status or when that chest tube is removed. Great job, you guys. Chest tubes are tough, but I know you can do it.